recorded. I forgot to turn on the recording, so it's starting up right now, which this is the important stuff anyway. But this session is being recorded, so if that's a problem, then you should turn it off. I tried to update everything as of today, and I was working on it just before we got on here. So the handouts for number 4 here, for 4, that one I just finished a few minutes before we started, so you may want to click on that one. It'll be a little bit different than the handout that we sent out earlier this morning. So the agenda, like I said, it's packed. I'm going to try to get you through preventive services, other service, Medicare secondary payer, common UB04 billing errors, and then how to complete the UB04 in less than an hour. Good luck with that. We'll try our best to do that. First off, preventive services. I always call it the most profitable patient in the world. He is this old, obese, drunken, smoking, dirty old man, because there are a lot of preventive services that you can do for people here. This started in 2011 when they added a lot of preventive services. Basically, what they did was they looked at the United States Preventive Task Force listing, and the preventive services that were graded an A or a B, they've provided that for Medicare patients. And there's a listing of about 30 different preventive services that we'll show you in just a moment. There are frequency edits because it's a preventive service, so there's no you don't have to be sick to get these, but there is a frequency. You can only get so many, so you want to double check and make sure that your dirty old man has these services available to him. So you want to check and make sure they're eligible, and that was I clipped and pasted that there. So there's the actual website there for the max eligibility services. So if you click there, you will get to a listing of the different max and how to get to whether the eligibility services are. Here is our first question of the day. So Danny will open up a poll, and basically it says effective 2011 Medicare covers physicals. Very quick little question there. I was trying not to say too much on there, but effective 2011 Medicare. Let's go in here and see. Let me see our polls here. I'll sort of glance at these and see how we're doing on this. We're doing pretty good. 63% of you guys have voted. We'll give you about 20 more seconds for everybody to get their votes in, and then we will stop it. Okay, Danny, let's go ahead and stop it now. Was that a good breaking point there? Tell me the answers, Danny.
Yep, 64% said false and 36% said true.
Okay, wow. Okay, so 36% said true and 64% said false, and it is false. It is false. Medicare still does not cover physicals, even though you think that it would. It does not. The Social Security Act explicitly prohibits Medicare coverage for routine physical exams. So if I go in and I try to get my 99397, my established visit for a well check for an old person, it is not going to pay. So if you send a 99397 as your HCPCS code to Medicare, it's going to deny that. It's these G codes. They will pay if you do what's required for this. The first one is the IPPE. Within 12 months of enrollment to Medicare Part B, you can get your initial preventive physical examination, even though it's really not a physical examination. That is the first thing you can get, and then after that, you can get an annual wellness exam. And if you want to see how to do those, there's there's a 10-pager on what is required, what the ICD-10 codes are for you to use, how to bill that. So this is one of those fact sheets, these Medicare fact sheets they put out that are very useful. So if you click into that, you're going to get this 10-pager. The first page will look like this right here. You definitely want to do that. So how would that end up being charged on your UB04? If you've been to the other sessions there, the IPPE is the only one that does not require a CG modifier, or not that and chronic care management are the only services that do not require a CG modifier. So in this case here, our G0402 does not require a CG on there. If you put a CG on there, it will pay. What most people tell me that. Our data service here is $128,2020. We charge $200 for that. So that's how that's going to show up on the UB04 form. Annual wellness exam, same sort of thing here. This looks like the same link as before, but it's not. There's 16 pages on annual wellness exams. There's an initial one, and then there's a subsequent one after that. If you're billing these services, the Medicare Part B fee for service, they pay them extremely well. The payments are well over $100 for each three of these types of visits: the initial IPPE, the initial annual wellness exam, and the subsequent annual wellness exam. So if you do have non-rural health clinic time, probably a good idea is to schedule these types of visits during that time, because they take up a lot of time by your providers to do these things. A lot of them take 30, 40 minutes to go through all the different things you have to do to do one of these exams. So if you can do it during what we like to call appointment only time, that is a really, really good idea if you're an independent RHC. If you're provider based, it doesn't really matter as much because you're probably getting that $150 or so per visit. Anyway, here's a description of the Medicare annual wellness visit. It's not a routine physical exam. You must include certain components to it. Is it the same thing as your beneficiary's yearly physical? And the answer is no. We basically just copied and pasted these answers directly from that fact sheet. But that's your annual wellness exam. You have enough information to find out the different information that you need to do those. Here is this tool here. If you click into this tool, you'll go into this interactive tool that Medicare has. There's another page down here. So there's actually 30 different preventive services on here. And if I were to go in here and to click into this intensive behavioral therapy, IBT for obesity, I would get a page that looks like something like this. And it tells you what HCPCS codes you want to use. It tells you the ICD-10 codes that you need to use, who is eligible for this, and the frequency that you can have in a year. Think about that, 22 visits for obesity training there. So to get me to lose weight, once I go on Medicare, I'm gonna have up to 22 visits a year if I can do what they say I need to do, which is lose a certain amount of weight and you have face-to-face encounters with them. And, and the reimbursement is really, really good. I mean, you get your all-inclusive rate for that. So if you're an independent RHC and you're at the capped rate of $86.31, you will get the full $86.31 for every visit. If you're a provider-based RHC and your rate's $150 a visit, you'll get $150 a visit for it. There's no, they don't take out any copays or deductibles for these. So that is a really good thing here. And so here's our next question: is most Medicare preventive services are not subject to copay and Medicare deductible. Now, not all of them, but most of them are not subject to copays or deductibles. And Danny has the poll open now, so if you can vote on that, you guys are doing really good on this one. You're gonna, I think people by now, since 2011, we've almost had 10 years of these services being provided. And let's get to 80%, and then we will close it down. 76%. Come on, we need a couple more votes, people. We'll close it down at 2. I feel like I'm calling for money on one of those telethons there. All right, let's close it down, Danny. We got a lot to cover here. So give me the answers.
We have 89% true and 11% false.
Yeah, it's right. 90% of you are absolutely right. The most of these, there's no copay or deductible for these preventive services, which that makes it great for if you've got a provider that's that's maybe they're not seeing a lot of visits or so, this will not cost your Medicare patients any money. I mean, I would get them on a registry and find out if Mark Lynn needs his G04447s. You got 22 of them you could provide, and I would be calling him and saying, Mark, we can get you to lose some of that weight and come on over. So however you would do that, this is a good way to get your visits increased and get some of your providers to be productive if they have a hard time. This is specifically for rural health clinics here. This was last updated on August the 10th, 2016. So it probably needs to be updated, because one thing I noticed when I started doing my math here, I'm like, okay, I counted up. Okay, I've got 7 or 8 here, and I've got, it totals up to 13 different preventive services. But when I go to the other thing, the Medicare thing that I showed you, all the little blue squares, they have 30 blue squares, and there's only 13 of these items listed in the RHC preventive chart. So we need to sort of reconcile those and make sure that we have all those sort of reconciled there as far as RHC services go. But this is a listing of services that RHCs can do. Here's IPPE. Here's your G code that you're going to use for that. Is it going to be paid at the all-inclusive rate? The answer is yes. Is it eligible for same-day billing? What that means is you can have 2 visits in one day. So if I have a sick visit and I get an IPPE visit on the same day, you're going to get all-inclusive rates. The co-pays are waived for that, and then that's where you can find more information. Notice I'm eligible for same-day billing when I go over to this page here. The second page, the annual wellness visit. Those are not eligible for same-day billing. That means if you have a sick visit and you provide this service, you're going to be doing it incident 2. And we all know what incident 2 means in rural health clinics. It means you ain't getting paid. Medicare is not going to increase your payment pretty much any for this. And we'll show you some things where you get a little bit of money on the cost report at the end of the year, but it's not. You want to do these as standalone visits if you can from a financial standpoint. Here is something that you should give your patients. It's a listing of all the different services that they're eligible for, and they can check those off to see which ones they have. And I would try to remind them that they need to go through and do these. They have different frequencies and time limits on when you can and cannot get these services, but it's important that you that they have that. Okay, 27. When preventive services are provided on the same day as an E&M, the charges are added to the E&M code with the CG modifier on the UBO4. Let me read that one again because I'm having a hard time with it too. When preventive services are provided on the same day as an E&M, the charges are added to the E&M code with the CG modifier. So you're going to add the charges. If I did my obesity training and I had an E&M code on the same day for a sick visit, then I'm going to add my charges for my preventive service, my G0447, to the CG modifier line. And that was a confusion question. The way I said it, when are provided on the same day, the charges are added to the E&M code. So, all right, Danny, you want to close this one out here so we can move on.
Yep, 55% said false and 45% said true.
Yeah, and this may have been just the way I worded the question, but the answer is false. You do not add, in my example here, my G0447, if you charge me $50 for that obesity training, you would not put that in the CG modifier line because there's no co-pays or deductibles on that. So you always have to remember, if you're doing a preventive service, if you have an E&M code and then you have a listing of maybe 2 or 3 preventive services on the same day, do not include those charges on that CG modifier line because the patient is not going to be subject to co-pays and deductibles for those services. And then here's the wording on this. When billing for preventive services, do not, and so you see that it's been bold and it's capitalized there, include charges into the roll up for the qualifying visit line. Medicare pays preventive health services at 100%. So if the only service you have on there is that G0447, like I said, Medicare is going to pay you $86.31, your full RHC rate. They're not gonna pay you 80% of that. So that's a reason. That's another reason why you want to try to do these as a standalone. So keep that in mind. Here is the listing of preventive services as well. This is the United States Preventive Task Force grade A or B services. So if you want to get your hands on that document, you can do that. And here's what your CG modifier is. Here's what your UB04 is going to look like. Revenue code 0521. Here's our revenue code of HCPCS code of G0101. You're going to put the CG modifier on this line. If you do it as a standalone service, you're going to put the CG modifier on there. This is the only service we're asking for. In this case here, we're going to charge $125 for it. You are going to get your full AIR, in this case, $86.31, but there's going to be no copay or deductible on that. So the only preventive service that doesn't require a CG modifier is that if you do it as a standalone, is the IPPE. That one you can put that on there and not have a CG modifier on there. But the rest of them, if you do them as standalones, you're going to have to add the CG modifier. And I know that's confusing and it's memorization because it's not a lot of logic to this. Okay, let's go on to the next one here, and here's the one that we just talked about. We have an E&M code. There's my sick visit where I'm going to do my CG. Here's my G0101. And this is my preventive service. In this case here, notice we are not going to roll up the $125 charge into our total charge line. We're going to keep it at 100. And when we're paid, and I always use it, and if provider-based people don't feel like you're being left out here, the reason why I use the independent camp is because the independent camp is the same for all independent RHCs. While provider-based rates, they can be all over the place. I've seen them to be, $300 or $400 or $500 a visit, all the way down to, $60 or $70 a visit. So I use the independent camp because that's going to help the most people. In this case here, we're going to get $69 from Medicare. The copay for the $100 sick visit, we're going to collect that $20. And then on the cost report, there is a place where you'll actually recoup some of your copay on there. And we do 170 cost reports a year. And for me to try to explain how that works, I could not explain it to you, but I know it works because I've done the math several times on it. What I would say is when you're getting your PSNR report, make sure that you get your 710 and your 71S. Your 71S has your preventive services on there from your PSNR types. And if you have problems getting your PSNRs, let us know. We can get them for you. We have secret methods to get those for you. But I always look for those and make sure that those are included when you settle up. I know a lot of times Medicare will forget to do that 71S, and you're owed money on that. And so that's another thing we tend to look at whenever we look at their work papers from Medicare. Okay, here is one where you have two all-inclusive rates paid in one day. This is an IPPE, and we had an office visit on the same day. In this case here, there's our G0402. We're not gonna put our charge, our $195 charge, into the CG line in this case here, but Medicare is going to pay us, if you're an independent RHC, they're going to pay you $69 for that, and then this G0402 line, they should pay you the full rate, the $86 rates for that. So that will be your payment for that. So you'll get two all-inclusive rates in that situation. This is a well woman exam. This is the way the charges are. So everything is going to go in revenue code 0521. Here is the HCPCS code for the well woman visit. It's basically, there's really no such thing as a well woman visit. This will be an annual wellness visit, a subsequent. So that's your G0439. We charged $150 for it. We did our breast and pelvic exam. We did our pap smear. Those are considered professional services. That pap smear, people want to build that as a technical component, but that, I guess it's the collection of that is going to be a professional service. So that's going to Q00091. That is going to go on your UBO4, and all this will be put together and be billed to Medicare. Notice how we do not do any type of adding the additional charges into the first line here on the CG modifier line. Just put the charges in and then leave them alone. And the patient will owe nothing on this particular visit. Hepatitis B, it's not really a preventive service, but it's sort of if you do have to give those, you basically going to eat that cost of that. If you have to give that to a patient, that's going to be considered part of your RHC visit. What a lot of people do is they will use Transact RX and things like shingles, hepatitis B. I think that's one of them. I'm not sure, but there's a listing of about 8 or 9 different vaccines that Transact RX will pay for. And if you think you have to give a lot of those, then you'd want to sign up for that. But the hepatitis B, you get stung with that if you do that. Okay, that's all that we have on preventive services right now. Before we move on to our next session a section of the webinar, Danny, do we have any questions? And Louise, do you have anything to say about preventive services on the way that you guys do them, or helpful hints for us?
I don't. You've covered it really well.
Okay, wonderful. And hello, Louise. I forgot to say hi to you when you checked in here. So hello. Thank you for doing this. You've been absolutely, everybody's complimented. They're saying, where did you get those people? They're so helpful. It's wonderful. So okay, give me your questions here, Danny.
Okay, the first one is, what line do we add the CG modifier to when we have a wellness charge with an office visit charge at the same visit?
Read it one more time.
What line do we add the CG modifier to when we have a wellness charge and an office visit on the same day?
You would add that to the office visit. The CG would go on the office visit. I think we had an example of that earlier. Is that right, Louise?
Yes, that is correct. The CG would go on your annual wellness or on your office visit. And the annual wellness, since it's covered at 100%, you don't roll that up, correct?
That's correct. So, okay, next question.
The next one, so the G0101 can be billed alone when a patient comes in and has a PAP. That's the first part.
Yep, that's true.
And then also, what would be the difference in G0101 and the Q0091?
What is that? I have no idea what that code is. So Louise, do you know what
Yeah, the Q00091 is just the collection of the PAP.
Oh, okay, gotcha. I missed the Q part of that. I missed the Q. I was thinking it's a different CPD code. Sorry about that. Okay.
And then do you bill an office visit with those?
You would not. If you didn't have an E&M code, you would not bill an office visit with that.
You mentioned on the cost report that the copay could be recouped for G0101, but isn't that preventive with no deductible and no copay?
That's the money you get on the cost report is when it's incident to, and you have an E&M code, and you have an incident to preventive service, and you are entitled to a copay. You will get made up that copay will get made up to you on the cost report. If you had just a preventive service, that's the only service that you provided on that day, you would get your full rate and you would not get any additional money on the cost report in that situation. Does that make sense? It doesn't make sense, but that's the way they do it.
If you go back to one of the slides that you showed, it does show that some of the preventatives do qualify to have a copay. Those are the ones I think you're referring to you can recoup.
Yeah. Well, there is some copay. you actually, it's even with the ones where you don't collect the copay from the patient. There's a way on that cost report where, and like I said, I can't explain exactly how it works, but the higher your charges are on there, the more your settlement is going to be. For you, the higher your preventive charges are on that cost report, the more you're going to collect, and it has to relate to those uncollected copays. Is what I was told by Medicare when I asked them that question. So okay, Danny, next question, please.
I have read in Medicare information that the CG would go on the charge that is the reason for the visit, which in some cases the main reason is the wellness. So in this case, add the CG to the wellness. Can you clarify again?
That's what Medicare tells you to do on the coding of it, is that you put it on you're going to put it on the sick visit. And that's just what Medicare tells you to do. Because Medicare may put out inconsistent statements every once in a while. A lot of their stuff is inconsistent. I think the theme is, as we've gone through this, is a lot of the stuff is not logical. A lot of the stuff is memorization, and that's the way that, as far as the coding of it, that's what Medicare tells you to do. Louise, you got anything on that? I mean,
I just think of it that's what my mother told me to do, and I'm going to do it.
That's what my mama told me. That's exactly the way it is. I mean, so that's what we have to do. Okay, any other questions before we move on?
Yep, there's oh, they keep coming in, but there are a couple more. So if you want them, I'll read them.
Okay, let's go ahead and do. Since we're on preventive, we'll stay with it because they're all preventive.
Okay, when the patient came for preventative and A&M, do we get reimbursement for A&M and preventive too? So 67 for A&M and 86 for preventive, or just the 86?
You're going to get, if you have an E&M code and a preventive, let's go back to our, let's see here. I must have gone through these last year here. So here we have, you are basically, here's the answer to that one. Is you're going to get $69 from Medicare. That's all you're going to get. The only exception to that is going to be when if this would have been an IPPE, you could have gotten 2 all-inclusive rates. But if you have a sick visit and you have a whole slew of preventive services on there and none of them are an IPPE, you're going to get $69 for that visit. That's all you're going to get. And from that patient, you're going to be able to collect that $20 copay on the E&M code. That's all you're going to be able to collect. So that's why it's not a really good idea to bring somebody in with a sick visit and then do all these preventive services on them at the same time, because you're gonna get killed when you do that. So I would bring them back to those preventive services. Okay, Louise, does that make sense what I just said?
Yes, it absolutely makes sense.
Yeah. Okay, next question then.
The last one, does Medicare cover any type of injections with a G0438 and G0439 visit?
Does Louise, what is that the annual wellness?
Those are annual wellness.
Annual wellness.
That's the annual and preventative.
Yeah, I don't think they do off the top of my head. Louise, do you know of any?
Read the question again.
Yeah, does Medicare cover any type of injections with an annual wellness?
You can do the incident. Well, no, you can't do the incident too, because you don't have a preventative copay on the G0438 and 9. So you couldn't roll up the incident 2 charges.
No. Yeah, I think my answer is that there isn't any. I mean, what I would do is go back and look at that fact sheet, the 16-page fact sheet on annual wellness exams. But I read it this morning and glanced through it, and I didn't see anything like that. So I wouldn't think there would be. But this doesn't sound like something that Medicare would do, is provide you with. I mean, you're talking about, that would be like an immunization, because it's a preventive service. So the answer to that would be no. How about that? That's a quick answer on that one. Okay, any more questions before we move on?
No, that's it.
Okay, good deal. Let's let's go on to the next one, mental health services here. If you do have an LCSW or there's another, and that's funny how I can never remember that, LCSW and an LPC. If you have one of those from a Medicare standpoint, it's a revenue code 0900. You're going to use for that. There's your HCPCS code. You're going to use a 90791, and you're going to add the CG modifier to that. And in this case, your total charge would be $200. So that's how you would put a mental health service visit on there. What if we had a mental health service visit and we had an E&M code on the same day? We always talk about, Alan Bragwell talks about the soft handout from the provider. In this case here, we would have a 0521, a 99213 CG modifier on there. There's our $100 charge for that. And then for our mental health service, 0900 is our revenue code. We're going to add the CG modifier to that line as well. So remember that. Again, this is a little bit different than what we've told you before. In this case, we'll have 2 CG modifiers in this case. Medicare is going to pay 2 all-inclusive rates, and we're not going to roll up this 200 charge into our first CG modifier line because it's on a CG line. So in this case, and you would collect copays on both of those lines there. So that is a sick visit and a mental health visit on the same day. That's 2 all-inclusive rates. What about when you have a patient that goes home, that they come to see you in the morning, and they come and you treat them for high blood pressure or whatever you do, and then they have an accident and they come back in the afternoon, they have a laceration? That's going to be a modifier 59. That's the only time you're going to use that modifier is in that situation there. So to summarize, we use a modifier 59, 2 qualified visits that occur on the same day, and they're both going to have the same. They're going to both have the same. The revenue code is 0521. And then here's a summary of that. If you have 2 E&M codes and they're for completely separate services, they've gone completely home, they've come back and they're completely 2 different ICD-10 codes, very rare. That's when you get 2 all-inclusive rates. You don't use those 59 codes with the E&M and a preventive service. Basically, at 59 is you're telling Medicare to pay me 2 all-inclusive rates, and that's not what's happening in this particular situation. And then if you have 1 E&M code and 1 mental health visit, do not use 59. Pretty much, you're never ever going to use 59 except maybe once every 5 years or so. Louise, you were telling me you've used it maybe once or twice since you've been billing. Is that right?
Yes, the only exception that I can remember we ever did, and we did get paid, was we had a lady that was here that morning, got her medication refilled, went home and got dog bit and had a severe laceration. And so she came back and we sewed her up, and we did get both AIRs.
Yeah, that is the only time you're going to use that. Something like what Louise just told me that's the only time you should be seeing a 59 modifier on your claims. Is that in that case? So, okay. All right. So when billing on the UB04, RHC should add modifier 25 to all lines that have incident to services listed. So remember our example from a couple of days ago when we were doing a shot there, we had the 96372. We might have had a venipuncture. We might have given them Rocephin. Each one of those, we're going to put a 25 modifier on there and make them happy. Oh my goodness, you guys are so smart. Look at you. We're doing really well on this one. Okay, we're going to give you a little bit longer. And Danny, you want to close that out real quick? Yeah, and then give me the answers.
Yep, 86% false and 14% true.
That is, you guys are very smart. That is right. 86% of you guys are absolutely right. You do not put that 25 modifier on there. And I know a lot of times you get in the habit of doing that because a lot of your insurance companies require you guys to put a 25 on just about every line that's not the primary payer line. And so So that is a problem. You get sort of ingrained in doing that. So so here are the modifiers. Do not use the 25, and then here's the 59. That's the one that you would use with two different visits there. Definition of if the commercial insurance companies would actually use the proper definition of a 25, which is two significant separately identifiable E&M services. A lot of times they require you to put that on, just any type of additional incident to service that aren't separately identifiable E&M codes for that. So that's why there's a lot of confusion on those 25s. Why is it important too? When Danny and I are counting your visits for the cost report there, and if we see a 25 on there, we're thinking that, oh, that's already been counted as a visit somewhere else, and we will not count that as a visit when we're counting your visits on the cost report. So don't use a 25 on there if you can. That's very important. And we have to get an understanding of how you're using these modifier 25s whenever we start counting your visits, whenever we prepare your cost reports. RHC, no globals and no groups for RHC. So here's how you bill procedures. If you do a procedure, you cannot globally bill that. That's in RHCs, you would not. I know we have a lot of OBGYNs, and from a Medicaid standpoint, here, especially for TennCare, is you'll have a prenatal visit. We will count those for our TennCare cost report, but when we do the delivery, it'll be a delivery only, and it gets very, very complicated on how you count those visits. So those are always very hard to deal with. But from a typical rural health clinic, if you're doing procedures on these Medicare patients, do not bill those globally. Bill it as a procedure only. And then here is a problem. What happens when Dr. Jones does surgery on Mark and he bills globally? Dr. Jones bills it globally, but he doesn't tell you. And we're in that 20-day or that 10-day global period for that particular surgery. And I come in and have a visit in your rural health clinic. If my visit is related to that surgery, I want you to check on it. Maybe I'm not healing right. You think I got infected or whatever. You can't bill for that. It's related to that visit. If I come in and what I'm coming in for is something completely unrelated, maybe a cold or something that's not related to that, then in that case you could bill it as an RHC visit. But you got to be very, very careful about that. So if you've got somebody if you can see if they come in from a surgery, you're going to want to ask them who did your surgery, just to find out, just in case if there's ever a billing question, you can go back and call Dr. Jones and say, well, how did you bill that? Should I eat this right? Luis, do y'all have this situation? Because to me, it seems like the RHC is putting in a really precarious position in this situation.
Well, since they don't have the global billing period, like if they come back and it's just Medicare, we go ahead and bill a secondary, like a level 2.
Yeah.
If they're coming back in for a recheck.
Yeah. Okay. All right. So you go ahead and bill it, and then have you ever had any of them deny because it was during a global period?
No, we never have under the Medicare.
Okay. All right. Well, good deal. It just, you almost had to be psychic to figure out if it was done during a global period and you did something during that global period related to that. For you guys that are owned by hospitals, here is something on the 3-day payment window. Basically, technical components, when they come into an RHC, first off, RHCs are not subject to the Medicare 3-day payment window for therapeutic services for things like the E&M code. So that's why you can bill. Remember, we had one yesterday where one of our earlier sessions where we said we had an RHC visit and we've been them to the hospital. Can you go ahead and bill for those and get paid for them? And the answer was yes. So in this case, even if you're owned by the hospital, you can bill for that office visit before the admission, even if it occurs within 3 days of that admission. Where you're going to run into issues, though, are technical components. If you do lab work, if you do x-rays on that patient and they fall within 3 days of a hospital admission, then you're going to have to bundle that into the inpatient DRG that was paid. So keep that in mind. I don't think this relates to the 3-day window doesn't apply to cause either, if I remember correctly. So that's the 3-day window. Here is your procedure only. You're just going to bill it just like a regular 0521. Here is your HCPCS code 10160 CG, and you're going to charge $150 for it. So very, very simple on if you do a procedure only. What happens if you have an E&M code and you do a procedure on the same day? You're going to get one all-inclusive rate. That's one reason why if I come in and I see Dr. Jones and I say, Dr. Jones, I got this big, huge ward. I see him because I've got a cold and I'm sick and I'm about to walk out the door and they say, oh, Dr. Jones, I got this big, huge wart on my neck. Can you freeze it off for me? Dr. Jones needs to say, yes, Mark, but come back on Tuesday and I will freeze it off then. But today, we can't do it today. You've already say you've used up your time, but because if you do it during that day and you go ahead and spend that extra time, you're just going to get one visit for that. So have them come back and get that taken care of, and you'll get your two visits, because that on the second day you would bill just like this, where you would just do the abscess and take care of it that day. If you do it that day, you're going to get one all-inclusive rate, and what you're going to add this $150 charge for this 10160. You're going to add that to your CG modifier line. So your copays will increase. It will look like you charge the patient a lot of money, though. In this case here, notice that total charge, that $400, is going to go to them, and they're going to see that it looks like you charge $400. That would be your inflated rate. Okay, E&M procedure on the same, and then on the same day, and here's your money that you're going to get from this case here. This is the same case that we just showed you before. You're going to get $69.05 from Medicare. Your copay is going to be $50. That's going to be 20% of $250. So your total collection in this case would be $119.05 from that. That's doing an E&M code and a procedure on the same day. So not a lot of money for what you did. Hospice is not covered. If a hospice patient comes to your rural health clinic, it's not going to be covered if it's related to their terminal diagnosis. And in this case, if it's not related to their terminal diagnosis, if you put a condition code 07 on the UB04, then Medicare should pay you for that. So, Louise, are there any tricks on hospice patients that comes into your clinic?
I wish I knew those tricks. We only had one that we did see a couple times. He would have like sinuses or whatever, but without doubt, he would talk about his hospice condition, and it would be documented that they discussed it. And at that point, then it would knock it out because she would make a recommendation to the hospice care.
Yeah,
so.
People have a really, really hard time getting those paid, because it's almost, how do you separate being in hospice from being sick? And that's what I found out from other people. That's what I hear from them most of the time. It's hard to get those paid. Okay, here we go. Home care plan recertification is not billable to Medicare by a rural health clinic. A, true. B, false. C, not as an encounter, but you can include some of the time in chronic care management. And this one's a tough one. I had to think about this one a little bit, and I'm not even sure if I still have the right answer. Okay, how are we doing on? Let me see here, Danny. I got to open up the polls section here. Okay. How much our time here? We got 56% of you guys voted. We'll give you about 10 or 15 more seconds here, and then we're going to close it out. So if you're waffling, I don't blame you. This was a hard one. And okay, let's close it out, Danny, because and then can you give me the answers for this one?
Yep, you've got 36% true, 20% false, and 44% not as an encounter, but includes some of the time in CCM.
Okay. All right. The 20% one false is wrong. That we can tell you that right now. We'll cut that. You cannot bill it. Home care plan oversight or recertification and oversight cannot be billed as an RHC encounter or any type of visit there. So that one is definitely out. The answer that we've received most of the time is that you just can't bill it, the true answer. So that would probably be an acceptable answer. And then when I was reading about the answer, I started thinking, what about chronic care management? It seems like they're doing the same thing as chronic care management. Could we include that time as a part of our chronic or CCM and get paid that $67? That would be great, because people are always upset that they can't include this home care plan oversight as payment from Medicare. And so when I was looking through it, it just happened to be in chapter 13 of the RHC manual, right where it should be. And it says, except for comprehensive care plan management that are a component of authorized care management services, section 230, which that's chronic care management piece of it. Treatment plans, home care plan oversight provided by the RHC to RHC payment patients are considered part of the RHC visit and are not separately billable services. So there is a piece of it that if they're doing a comprehensive care plan, then that you should count that time towards your chronic care management, that 20 minutes of time. And then one of the questions, I didn't find the answer, Louis, you may know this one, may not. Somebody was saying that their billers were requiring a new comprehensive care plan every single month to bill chronic care management. And I said, that didn't sound like true. That didn't sound true to me, but.
We haven't done any, but my understanding was they had to have an agreement and then you could do it once a month. It didn't specify you had to have face-to-face within 30 days.
Yeah, and the chronic care management, like the comprehensive care plan, I just can't see them doing one every month on that. So if somebody knows the answer to that, please feel free to let us know on that one, because that was, and I have that question going up to ChartSpan, so ChartSpan is going to give me the answer to that one as well. There are the codes for that one. Because there's no face-to-face encounter, RHCs cannot bill the G0179 or G0180, and it seems like they changed the rules a few years ago where they actually required a face-to-face encounter for this, at least initially. And I think when I asked Captain Axelrod, she still said, nope, you still can't count that as a billable encounter, even though you had the face-to-face encounter. So something weird. I've always thought that they've done weird on this, and I haven't agreed with it. So it's one of those other weird ones. Okay.
A face-to-face is required within a certain time frame of starting home health, but you would get your air for that, so it wouldn't count as a double.
Yeah. That's Danny, do you have any more questions here before we go on to Medicare secondary payer?
You've got quite a few.
Oh my goodness. Okay, let's go ahead.
Yeah. What about, sorry, the printer's going, it's almost done. What about a provider-based clinic billing a procedure and the medication? Do they still need to bill the medication under the hospital's UB and the procedure under the clinic UB?
You would not, no, you would not bill the medication out of the hospital. That's a do not pass go, do not collect 200. You're going to have to add that, whatever the medications that you're providing, you're going to put that on the UBO for, and it's going to get paid incident too. So, next question.
If a patient comes in to have a suture removal and we did not do the initial suture, can we bill E&M for the suture removal? How would we bill or handle this situation?
Would suture removal equal up to a 99212 visit? I think that's where the question with me would be. Louise, what do y'all do in a situation like that?
There is a specific rule, and I don't remember exactly where I found it, but it goes back to you have to talk to the surgeon to see if they counted the global time frame, and if they did without their modifier saying they're handing off part of that, then you cannot bill for it.
Yeah, you're exactly right. If the surgeon billed procedure only, then you would definitely be fine on that. If the surgeon billed globally, then you're definitely not going to get paid for it. So that is a good point. That's a good point, Louise. Okay, next question.
Can we bill for hospice certification or recertifications?
Yeah, I would not think you could. Louise, do you know the answer to that one?
Not unless you have a face-to-face before they go on to hospice, but other than that, no, you won't do anything after that.
Yeah, I would not think you'd be able to get paid for that. Okay, next question.
Okay, regarding the 59 modifier, what if a patient comes in for a nebulizer treatment, goes home, and then has to come back for another treatment? Would
That would
modifier
not qualify. Those are not going to be for different ICD-10 codes. That's not going to be a 59. That's because that's related to the same exact ICD-10 code. Is that right, Louise? Is that the way you'd look at that?
If it's incident 2, you could probably change the units of 2 on that nebulizer and roll it up into the AIR.
Yeah, so you get a little bit of money for it, but you're not going to get 2 all-inclusive rates for it. And you would not use 59 modifier. It would not qualify for that. Okay, is there more questions?
Yes. What if a hospice patient comes in to see a provider, and that provider is also the physician over the hospice clinic? The hospice clinic is not owned or affiliated with the RHC. Can they bill if they do not discuss hospice problems?
That's the problem, is if it's related to something if they're coming in, I mean, condition code 07 says that you treated that patient for something not related to their hospice condition. The problem is almost everything is related to that hospice condition. And that provider, you should be getting your money from the hospice. The hospice is paid a flat fee for taking care of that hospice patient. It's a lot of money. And so what you really should be doing is billing that hospice for that patient coming over and you treating them. Is that the way you see it, Louise?
I do, and I would be concerned about that if they're using the same NPI for that provider, that it would flow up a audit flag.
Yeah, because that's really hospice service there that should be paid through. Again, the hospice has paid a lot of money to do those type of things. You should be sending them a bill directly and then them paying you. Okay, next question.
Danielle says, I have billed the HHC recert as an incident 2, and it is included in the AIR within the 30 days.
Okay. All right, good deal.
Can we bill the recertifications G0180 under the other place of service that is not RHC?
If you do it, so you're saying you will bill the Medicare Part B fee for service, is what you're saying. And I've seen people do it. I don't tell people to do it just because it says very specifically that you shouldn't be doing that. And then there's another part of me that says, well, if you do it and you document it during non-rural health clinic time, and you bill it to Medicare Part B fee for service, and you pull that cost out of the cost report, then you're probably okay. And we have to pull out your compensation because you're not getting compensated for it. If you do all those things right, then you're probably okay. But I'm a little bit more conservative than a lot of people, and I say the chances of you doing every single thing right on this is not worth that $40 or $50 that you're getting for that code, and I wouldn't do it. So that's just sort of my conservative nature on that. Oh,
there was
okay.
another question that said, can we bill certification or recertifications Part B? But you kind of just talked about that.
No, you definitely. Well, again, you can bill the Medicare Part B if you do all of those things that I just said during non-RHC time. Pull it out of the cost report. Make sure whoever's doing your cost report knows that you're doing it. Make sure it's during non-RHC time. Make sure you pull that physician, that provider compensation out of there, and make sure if you have an agreement with that provider, say that the RHC is not paying for any home health care plan recertifications and oversights, that will not be compensated for that through the rural health clinic. So yeah, that's one that everybody has a problem with, and I think Medicare is doing it wrong. But we have to tell you what Medicare tells you, what they expect you to do. Okay, what Mama says, that's what we're doing. You have any more, Danny?
This is the same person is asking more about that. It says, so is G0180 will go under the cost report?
That's exactly what they tell you. That's what they say. It's basically incident to. If you're independent RHC, you ain't gonna get paid for it because you're probably way above the camp. If you're provider based, that time will be a part of your cost per visit, and you will probably recoup a very small percentage of it. Okay, any more before we move on?
Yeah, there's one more. It says,
One
what if,
more?
yeah, what if the patient had an office visit, but CCM was billed the same day?
You can do that. You can have an office visit and a CCM on the same day. Okay.
That's it.
Okay. All right, that's it. Okay, Medicare secondary payer, and I thought that was going to be the easy part. This is always the hard part on the billing session here. Medicare secondary payer. If you were in the session last week, we told you that the MSP form had to be completed every single visit, or you have to at least ask those questions for the MSP. So keep that in mind. Medicare secondary payer. What it is, it's a term used, but Medicare is trying to determine that they're not responsible for paying this healthcare claim. They're trying to find somebody else. And this is if you click into this slide right here, there's a presentation that CMS does on Medicare secondary payer. It's got about 24 different slides in here. And it talks about, here's the two major groups there that you really need to get in your head is group health plans and non-group health plans. The non-group health plans almost always are going to be paid primary, and the group health plans, most cases, they actually will pay primary is the way I sort of look at it. Like 3 out of 4 occasions, the Medicare will be primary and the group health plan will be secondary. And probably like 100% of the time, if they're a non-group health plan, Medicare is going to want the non-group health plan to pay primary, and then Medicare will come in paying secondary. It's sort of the cheat sheet that you use in your head. So what is a group health plan? That's basically if you work for Walmart or some big company and they have group health insurance, which I don't even know if Walmart does or not. But if you have a good employer and they have group health insurance, that's going to be a group health plan. You're going to want to know if there's more than 20 employees in this plan or more than 100, depending on the age and whether the patient's retired or if they're on disability. There's all sorts of issues there that as far as this questionnaire is. So number 30, here we got that. And I think I gave you the answer to that just now if you were listening. Non-group health plans will almost always pay primary and Medicare will pay secondary. So we should, if we were listening, we're going to know that. So if you haven't fallen asleep yet, then you're going to get the right answer on that one. Okay, and all right. Danny, you want to close it out because we are running out of time here.
Yep, 77% said true and 23% said false.
And 23% of you were sleeping during that one there. So the non-group health plans will almost always pay primary, while Medicare will pay secondary in that case. So the answer to that one is going to be true. Okay, let's move on here. And then this is the non-group health plans. This is just defining what those are. Those are things like liability insurance, non-fault insurance, workman's comp, State Farm, Farm Bureau, if you have a car accident, those types of things, or an insurer for that. And so that's what the non-group health plans do. And you can get a conditional payment from Medicare if these guys are notoriously slow, because typically there's lawsuits involved in this. They are notoriously slow. And if you haven't been paid within 120 days, then Medicare will pay a conditional payment to you as well. So keep that in mind. There's a way to get at least some of your money ahead of time with those conditional payments. Here is the Medicare secondary payer fact sheet, and it's about 16, 17 pages long. It is really wonderful. So here's what it tells you what the MSP is all about. It's to protect the Medicare trust fund. So in 5 years from now, when I get Medicare, yay, then there will be some money left for me to spend. Saves about $8.5 billion a year. It helps to protect physicians and providers' revenues, and it avoids Medicare recovery efforts, because they will try to recover this money from you if they find out later on that insurance company was supposed to pay and you've already billed them for that. Then you end up having to pay back Medicare money. So in this case here, when does Medicare pay first? And here's what you're responsible for doing. You have to gather MSP data to determine who the primary payer is. And then once you figure out if you're primary or secondary, then you have to bill in accordance with those regulations there. And then how you bill, how you give them the proper information is by providing information with value codes, condition codes, occurrence codes on your UBO form. And I used Part A, institutional provider, because rural health clinics are considered to be institutional providers, and you have to follow the rules of hospitals, which makes it very, very hard for you guys. Here, this table, and I won't read all this table to you, but just go into that fact sheet and pull those tables, pull and get that fact sheet. This is straight from that Medicare secondary fact sheet. So this will tell you, look at that, you can see that Medicare pays first on, this is a group health plan. In this case here, you're 65 and older, and the employer has less than 20 employees. Medicare is going to pay first. If the patient is 65 or older and is retired and is not working, then Medicare is definitely going to pay first. If the patient is 65, disabled, and still has a group health plan, Medicare is going to pay first. So you can see there's a sort of a theme there, is that Medicare is going to pay first. And then here's a couple of situations where Medicare pays secondary when the patient is 65 or older. So, and then here's a few more listing there of more common issues there. I definitely will not go over this section of it, but you can take those and memorize this. And then here's a nice little one-pager list that has some information about this. It's basically the same information that we just showed you. It just made it a little bit easier for you guys as well. And then remember, we said you have to do a form every single time, or at least some type of documentation. Here is a 2-pager for you guys. Or actually, no, this is the actual chapter 3. It's chapter 3, MSP provider, physician summary, and other supplier billing requirements. In this case, this is about a 53-page document, all about Medicare secondary payer. This form, it has the actual form that you're supposed to use, which is like 16 pages long by the time you print it all off. I don't think you can give your Medicare patient a 16-page form. And so keep this. Okay, so our next question is, how long must an RHC keep evidence that the Medicare secondary payer form was completed? 1 year, 3 years, 5 years, or 10 years? Yeah. Okay. And here we go. Y'all guys are doing good on the voting here. Okay. Wait just a little bit longer. And Danny, go ahead and close it out because we're running out of time here. So, okay. And so what are our answers here?
Okay. 17% for 1 year, 19% for 3, 22% said 5 years, and 42% said 10 years.
Unfortunately, the majority of you guys are right. It is 10 years. So you have to maintain documentation that you've asked these Medicare secondary payer form, this Medicare secondary payer information for 10 years. I know these guys, there's like 3 guys I know from New Jersey. They live in this house and they do Medicare secondary payer audits for the government, and they're contracted. And what they'll do is they'll go in and look at a sample of your claims, and they'll look at a sample of 100, and then they'll look at 100. And if your Medicare secondary payer wasn't done in 10 of those 100, Medicare is gonna ask for 10% of all the money that they paid you for a 3 or 4 year period of time. And then these guys are gonna get 30% of that. And they make millions. I am definitely in the wrong business here. They make millions and millions of dollars doing that for the federal government. And so keep in mind that you have to maintain evidence of asking these Medicare payer, secondary payer questions for up to 10 years. So, and the consequences can be really, really bad. I know I've had several people that have had these MSP audits, and it's never good. This form here is a one-pager that you can use that one of our clients came up with that answers these questions here that you can do. I know Louise has a program where they have them fill out a form very similar to this, and then every time they come in, they basically have an audit trail in their computer that they click on a button that says, I asked Mark all these questions here. And so that's a good way to do it. It's going to be in your computer. It doesn't say, Medicare doesn't say they have to sign it every time they come. You can put it in a computer electronic format. It will be perfectly fine, but you need to do this every single visit. Here, this is another form. I think it's from an attorney. This is a 2-pager. It's actually It's actually a PDF, and you can actually fill it in with computers. With these little things are clickable in here as well. So there's a 2-pager that you can use as well. And then here's some information on the Medicare Secondary Payer Lookup tool. So you can look up information regarding whether a patient is primary or secondary. And this lookup will go through, it has like a little, it'll ask you questions, and when you answer the question, it will tell you by the end of it whether Medicare should be primary or secondary. So it's a pretty neat little tool as well. Here's some of the typical Medicare secondary claim rejections, and so here's some of the reasons why a lot of claims are rejected. And I think this is probably in the wrong spot there. They should have been in the place where we had the billing issues there. But here's some of the things that Palmetto published this last year on claims were being rejected. Then here is something that Palmetto goes in and have an explanation of condition codes, value codes, remarks, occurrence codes, all of that. I would definitely take some time to go in there and go through this module. This is on Medicare secondary payer coding, and that will be well worth your time to go in that as well. Also, CGS, this is about a 24-page booklet on how to bill Medicare secondary payer. And it's got your condition codes, your occurrence codes over here, your value codes, how you use those. And then it has this sort of decision tree on whether a patient is Medicare secondary or primary, and goes through that. It also has the BCRC number on here, the Benefits Coordination and Recovery Center. There's the phone number for that if you have to call that and provide them with information or have to ask them questions. And then here is the Coordination of Benefits and Recovery module that's in Medicare CMS right now. If you want to go into this Medicare payer recovery portal, here is how you can enter that. If you just click here, that will take you to that as well. And then this is the Benefits Recovery Coordination overview of the services there. And this last page here, this is the actual website where you can go to. It has the phone numbers, has all the different information about benefits recovery and coordination services there. Louise, can you tell us everything you know about Medicare secondary payer? You could tell from me going through those slides that Medicare secondary payer is the part to where when I get to it, not billing claims, it's where my head explodes. I think it's the most difficult part of billing is doing Medicare secondary payer billing. So do you have words of wisdom for us on this one that can get us out of the weeds?
The most common one you're going to see, of course, is the group insurance. And you have to remember to change and add that CG modifier. I know Cigna, Aetna, and Humana will not accept the CG modifier on the primary claim. So I have to add it once we get the payment before the Medicare claim goes out. The other one is when you have an automobile accident on a Medicare person, it is very important to get the letter stating that benefits have exhausted, or Medicare will not accept just your word for it. They want that letter to show it. And also getting the patients to understand they have to notify Medicare when that claim closes. or they'll leave it open for years.
So do they have to call this benefits coordination and recovery center to do that, or how would they do that?
What I did with my husband when he was involved in one was I kept that benefit exhausted letter, and then I went to Medicare.gov, which he's enrolled in, and uploaded it for him, and then they closed it.
Okay. So you have to work with your patients to make sure that they, once these period, when the insurance period is over, there's no more lawsuits, you need to get this thing closed out. But otherwise, you're going to have problems when you start trying to file your claims. Okay. All right. Well, good. Well, very good. I hate to even ask if you have any questions in this section, Danny, because dumb looks are still free on this one here. So.
There's one that says, can the CMA do the Medicare secondary payer questionnaire every visit, or does the provider have to do it?
Oh, the provider doesn't have to do it. The CM, it's going to be your insurance. It's going to be your receptionist that will be doing it, or somebody up front. They will basically go through a listing of those questions very quickly, and then say, okay, yeah, we ask Mark the questions, and basically, Louise, what do you guys do? I guess that's probably you can probably answer better than I can.
Well, our receptionist does ask every time they see Medicare on the encounter sheet that we print out. Yeah. When they see Medicare, they automatically ask. Getting it documented into the chart seems to be the issue, because who has time to click another button and download it? We're using Isaiah EMR, and what we did was created a handout with the defaults to the basic no's, and then all they have to do now is just timestamp that and add it to the chart. That seems to be the easiest way, but then again, some will get missed.
Yeah, it's almost impossible to get this. What I would tell you to do is be very, very careful about if a patient comes in and they've got a broken arm, or they look like they've been in a car wreck and they're all beat up, is you want to get that MSP form out and get them to fill one out at that point, because Medicare is going to be looking for, if you're doing x-rays for a broken arm, they're going to want to see, why did Mrs. Jones have a broken arm? Well, did she fall at Walmart? Did she have a car wreck coming home from church? They're going to want to know that, because they're going to look for Farm Bureau or Walmart's insurer or somebody to be paying for it. So if you have something like that, you definitely have something where you want to do that MSP form, because Medicare is going to be looking for somebody. Okay.
You will also find a lot of times they will tell the receptionist, no, I don't have anything like that. And then when the nurse is going through triage, they'll say, oh, I fell it somewhere. So there's going to be some training needing to go through the whole clinic, really.
Yeah. Okay. Yeah. This is probably the hardest part, and some of the most misunderstood parts of RHC billing and Medicare billing. If Palmetto is your MAC, they do the great thing called MAC Oktoberfest, and every October, and then in the spring too, they'll come out and do some presentations and actually go out and meet the people. I know they come to Chattanooga at least once a year. I know they go to Birmingham. I know they go to the places in this area. And I was at one of the sessions last year, or maybe it's the year before last. They had this error report here, and I wanted to say Alabama had a 16.1% error rate, Tennessee 5.7%, Georgia 6.1%, and then the overall 10% of you guys have it's a 10% error rate in your claims going in from Medicare, that is high. I mean, the usual denial rate is usually less than 5% if everything is running correctly there. So there seems to be there's a lot of education that needs to be done to lower those rates. One of the things that Palmetto was saying was to make sure that your physicians are signing off, or your nurse practitioner PAs are signing off on those charts before you submit those. They found some issues there where the physicians weren't signing off here. So before you can submit a claim to Medicare, that physician, that provider has to sign that chart that is complete. Otherwise, Medicare considers it not to be documented, and you shouldn't be submitted that claim to Medicare. I know a lot of you guys want to get your claims out in 1 or 2 or 3 days, but you've got to make sure that they're signed before. Also, consent to treat. Make sure your consent to treats are up to date. And by up to date, I mean signed and witnessed within 1 year of treatment as far as a general consent to treat. Now, if it's a specific informed consent to treat for a procedure that you're doing, then you would need that before they did that procedure. But just in general, just for seeing the patient, you're going to have a consent to treat signed within 1 year. And the state's inspectors will look for that as well. They will write you up for that every time. Quad A will write you up for it. The compliance team will write you up for it. They'll look at 20 charts. And if you have 1 or 2 or 3 that the consent to treat form is not up to date, then you will get written up from it by them. Louise, what do y'all do on y'all's consent to treat? Y'all?
We need to work on that. We do. The providers are good about documenting it, and we have a basic form at the front in with our initial paperwork that the patients do sign giving consent. But as far as individual consents, the providers are supposed to do that.
Yeah. What I would, most people do is every January, if you're, even though you typically the typical question is, they're going to say, have you been here this year? And you're going to say no. They're going to give you the whole package of information to re-sign every year. And that's really the best way to capture that information as well. If the patient doesn't come within the year, I mean, a lot of times they'll get you on that one. But you know, that's really about the only thing you can do is just once a year, starting in January, is try to get your forms re-signed by everybody, your privacy forms, your consent to treat forms, all of that. And it should be built into, like Louise said, is you have a little package that you give your patient the first time they're there in their initial visit, and then the first time every year thereafter. And then ABNs, not using ABNs correctly, that was one of the things that Palmetto had noticed as well. Modifier 59, they were using it incorrectly as well. So you want to be careful about 59 should be used very, very few times. Okay. Completing the UBO4 form, this will actually go really super fast, I think. So let's try to get through it quickly. Here is a download here. There's a 11-page form on completing the UBO4, or they call it the CMS 1450 or the 837I, the institutional is the form. So there's a lot of links in here for getting you more and more information from this fact sheet. Here is the first page of this, and just to see what's in here. Also, direct data entry is something that you guys should be interested in. Most of you guys should have access to DDE. A lot of people use something called Ability, and that's a company that has access to direct DDE, and they have some other services as well. Louise, do y'all have direct data entry, and how do y'all use that, the DDE system?
We don't. There was a cost involved the last time I checked in it, and I hadn't checked in it lately. But I do corrected claims electronically, usually through the EMR.
Yeah.
And I check e-services to find out why the denials are.
Yeah, if you have a good system, a lot of your better EMR systems will have a DDE sort of built into it, or they have like a link into it. You know, it sort of does it through their system. You don't even know you're in DDE. But that is something that you really do need, is to be a part of that. I think there's a program, PCACE Pro or something like that gets you some access to it, and I think that may be even free. And Ability, I think Ability is not too expensive. It may be like $100 or so to get access through Ability as well. So if you don't have a good system like Azalea that doesn't have that direct access to direct data entry, that is something that you really do need, because it's very helpful at correcting claims, adjusting claims, doing MSP claims. That it's very helpful for that. So completing your UBO4, there's 81 field look. It says form. It always messes me up. I always say form. There's 81 field locators on the UBO4 form. You only have to put in 28 of those to make your claim pay. So don't try to fill in all 81 of those. Janet Linton in 2012 put together a great presentation on how to fill out the UB04 form. That we're changing over to something called the 5010 transition. And so I basically made a cheat sheet out of it. So this right here, if you want to click right here, that's going to get you a 6-page cheat sheet for how to complete your UB04. So let's go through here. Then here's the claims processing manual that you want to go to, where you can read more about that. Also, Chapter 9, and I should have put this on here, but I completely forgot about this. Chapter 9 of your RHC manual has exactly how to fill out that UB04. So I should have, that was dumb of me. I'll actually fix that for our last slide presentation whenever I finalize the slide presentation. But that is very helpful. Here are some of the major guidelines when we talk about this. Field locator 14, the type, number 1 is for an emergency, 2 is urgent, 3 is elective. Typically for RHCs, you're going to use a 2 or a 3 for a type of admission is basically what it is. Field locator 15, the source is typically going to be 1. A non-healthcare point of origin is where your patients are going to come from. So people got confused about 14 and 15, and then 17 status. Typically, they're going to be discharged to home. So 01 will be, you're going to send, the patient's going to go home. They're going to be, and there's some terminology. I forget which state it is. Arkansas, if you don't put the right terminology in there, the state will jump onto you. Patient discharge, ambulatory, no distress, or something, some type of wording like that. So form locator 1701, discharge to home or self-care. That's what you're going to fill out 99% of the time. Field locator 70, patient reason for visit. That's going to be your ICD-10 code. Your taxonomy code is going to make sure it agrees. Make sure this is in your MPI number enumerator. It's 261QR1300X. That's a taxonomy code for a rural health clinic. Make sure that your name of your facility has the correct 9-digit zip code in there. Make sure your tax ID number matches that MPI number, and your taxonomy code match exactly. They will not pass edits if you don't have that. So keep that in mind. NUBC, they're the people who are in charge with the standards for UB04 submission as well. So if you want to click into here, that will take you to NUBC, and then there's some more claims processing information is there. Here's your bill types. I think we've talked about your bill types before, so we'll go through those quickly. Here's your revenue codes. We've told you that already, so you know your revenue codes. Here's the revenue codes for ancillary services. So we've gone over those. Here's your field locators right here. Basically, you can see, is it required? Yes or no. And so if you don't have to put it in there, then don't do anything with it. If it's required, obviously you're going to fill out that information in there as well. Field locator 4, that's going to be your bill type. So you're going to put that on there. And these we can skip through them really quickly. Here's, I think all of these are really simple. Admission date, admission hour, those are going to be NA for what you guys are doing. Admission type, field locator 14 and 15, those are the ones you want to look at pretty closely. Make sure that you use the right ones for those. 16, 17, 18 through 28, this is where you're going to use your condition codes. 07, we talked about that today. If you're sending in a claim for denial purposes, you want to put a condition code 21 on there, and that will help you with that. So that's going to be your condition codes. And then you should all know this one by now, because we talked about this enough. Condition, occurrence, and value codes are mainly used for reporting of Medicare secondary payer information. So let's cross our fingers and hope that we were still around for this one. And give you just a few more. We're up at 40%. Let's try to get a little bit over 50%. Okay. All right, Danny, let's close it out right there. And give me the answers.
Yep, 76% said true and 24% said false.
And 76% is right. It's true. And this is probably not the best question in the world because it's a little bit subjective, but condition, occurrence, and value codes are mainly used for reporting Medicare secondary payer information. It's probably not the best question we've ever had, but I think for the most part that's true. Louise, is that the way? Is that pretty much true, or did I have a bad question?
No, it is pretty much true. The one exception I would add, well, not really an exception, when you have some Medicare secondary claims, secondary payers to Medicare, you're going to use your value codes for like A1 for deductible, A2 for coinsurance on those. For like our crossovers don't go to AARP, Bankers Fidelity, and a few others.
All right, perfect. Okay, let's see here. Let's go ahead and this is something from CGS that it is really good. It has all the condition codes, has the occurrence codes, and all the value codes in one place. So you guys can find those when you need to look those up. And then there's where the condition codes are as well. Lots of resources for your condition codes there. And then continue on. Let's see here. None of these are required, so we'll go through those real quick, and we'll just skip those. Occurrence codes. Occurrence codes. Remember, they only happen for a period of time. So usually there will be a date involved in an occurrence code, and so they cover a span of time. And then value codes. Typically, when you use value codes, you're going to be reporting money. And value codes is typically used when you tell Medicare that from your primary insurance company you were paid $50 or $100. I think there's a value code. Was it 44 or is there a condition code? Which one is it? Luis, you help me out with this. Is there a 44 condition code or value code that you use and then you put an amount with it? How much the insurance company paid you?
The common ones I use is 12 or 43, depending on if they're retired or disabled, and that gets the amount paid by the primary insurance. And then 44 is the allowed amount. So we're going to get the difference between the two.
Okay, so that's good. So, all right, let's move on. Thank you, Louise. Form locator 42, we know that's going to be your revenue code. 43, that's just a description of the visit there. 44, your HCPCS codes, again, effective 4/1/2016. Those are required. Your service date will be the one date. Remember, you don't span bill in a rural health clinic. You only have one date of service. Even though if you have incident 2 services that occurred 29 days from the date of the office visit, you're not gonna put that span of dates on there. You're just gonna put the visit date on there, the office visit date there, and then the service units there will be there. Total charges, we talked about that one a lot on whether that's inflated or not. And then some of these are not used here. Payer name, health plan ID. I think the important part there's on your health plan ID too is make sure you get the right order. If Medicare is secondary, they're going to be the second item on there, and if in the commercial insurance company would be the first plan ID on there. Is that right? Is that right, Louise? If I'm remembering correctly?
That is correct. There is an exception with Tennessee Medicaid, and I forget exactly which line it is. We had to hard code it in our old system because it kept putting it in the wrong one.
Okay. All right, we'll get, okay, let's move on because we're running way out of time. So a lot of these are not required. Oh, let's go back to 56, MPI number of the billing provider. This is important. That is your RHC MPI number. You have to have an institutional MPI number or organizational MPI number to be a rural health clinic. And so in that case, you want to use that. So everybody, if I'm a nurse practitioner and Louise is the doctor, we're all going to be using the same RHC MPI number in form locator 56. Let's see here, insurers names, all that sort of stuff there. Document control number 64, that's going to be important if you have an incident too, if you're changing your charges. you're going to have to identify which UB04 you're correcting, and that's you're going to get that from your document control number. And let's see, condition code D1, change of charges is what you're going to be using as your condition code when you do that as well. Okay, so that's going to be very important when you have to adjust a claim. You're going to have to use that field locator. Let's see, principal diagnosis, that's your ICD-10 code. You see how old this presentation is. It's got ICD-9 on ICD-10 code. And then let's flip over here, 76, the attending provider MPI number. So Dr. Louise and nurse practitioner Mark, that the person who actually sees that patient, that's where you're going to put their MPI number as well. So that's going to be very important that you get the proper attending MPI number there. And then finally, 81CC, this is where you can put remarks. You can put in your taxonomy code, make sure it's correct. If you have a change of charges, you can write that in there. If you have a condition code D1 for a change of charges there. Questions, comments? Okay, we finally made it through in an hour and a half. That was pretty gruesome, wasn't it? But I think we got a lot of information out there to you guys on how to bill as a rural health clinic. Probably gave everybody a headache like you gave me on this. This is a hard one. So Danny, do we have questions?
Yes, sir.
All right, let's try it.
All right. I know we have to ask about the MSP questions each visit, but do we have to document the asking of the questions for each visit, or just have the patient sign once per year?
You need to document every single visit. Now, what Louise said was they had them sign once a year, but somewhere every single visit, you're gonna have to have some type of documentation that they did. You don't have to have them sign a form. You don't have to have their signature each time. Somebody somewhere needs to make some type of notation that you asked Mark Lynn, those questions there. And typically, if you just start off questions of, has anything changed since the last time you were here? That will get you in the right mode with that patient. So Louise, you got anything on that?
No, like I said, our receptionist is great about asking it. Most of the time the patients say no changes. Then they may tell the nurse or the lab person at the end of the visit that there's changes. So there's really, just document what they tell you, and then if the claim's denied for whatever reason, fix it then.
Yeah, and there is a condition code, or I think there's a condition code that's like D8 or something that says we asked the questions, but we couldn't get the information from the patient or something like that. So there is sort of a safety code for you there. If you ask them to fill out the form and they wouldn't fill it out, that is one way to cover yourself, is to use that particular condition code on your claim. Next question.
Hey, I know this is unrelated, but when Palmetto returns a claim, why don't they put the reason code that they return the claim details in Palmetto e-services?
Louise, do you know if you have a return claim? I guess there's two different types of claims. A return claim, they send it back because it just didn't meet the basics of being paid. While there's a rejected claim, if they reject their claim, they will tell you why they rejected it. But do you know the differences there? Because I've been always fuzzy about that too as well, Louise. Why?
Yeah, and I've even called them and asked them, why couldn't they let the clearinghouses know the claim was returned? Because the only way I find those is when I'm doing my aging and I actually log on to e-services to find it. If you can get it within a certain amount of days, you can put a code on and change it right then. But I agree, it would be great if they would put that reason code, because then you have to call the IVR, find out what the code is, look it up on the website, and half the time they're not on the website, so then you've got to talk to the customer service anyway. So they really do need to work on that.
Yeah, used to in the old days, there used to be a report, and Louise, you probably were around when they sent what they call 201 reports, and you get them every Wednesday, and it would have like a listing of the claims that were going to be paid, the claims that were paid, and the claims that were rejected. It have the reason codes on it. And you can look through those 201 reports and you can know exactly what your status was with Medicare.
Yes,
And,
I do remember those. They were wonderful.
yeah, there's nothing
I
like
do-
that anymore. I mean, so
I do
basically,
I do understand that the DDE does have the codes on there. So if maybe you could include where those places that you mentioned, it might be something worth looking for.
yeah. Ability is the one that I know that a lot of our people use and they love it. I hear rave reviews about Ability, and we're not getting paid for to say that. So, so those are good. Okay. Next question.
What do you do when a patient comes in and has their IPPE an annual wellness visit, and then they come back in before 365 days and the doctor does another annual wellness visit?
That's what I was asking.
Yeah. You probably eat it because you've not met your frequency guidelines on that. That's the problem. Is you need to check and see if that patient is eligible for, like, anytime you do an annual wellness exam, you want to double check and I forget what you would call that, but pre-eligibility to see that they're eligible for that, because that's a lot of your doctor's time. And if they've already had one, these Medicare, they're like me. They're losing their minds and they don't remember that, oh, I saw Dr. Jones about 3 weeks ago and we did the annual wellness exam there, and then they come in and schedule one with you. So you want to double check that. You can do that through DDE. You can do that through, Louise, what is that called with Palmetto? They have, I forget the name of it.
E-services.
E-services. Yeah, they changed names. So when it was Cahaba, it was one thing. With this Palmetto, it's another. So I lose track of what the names are of these things. But e-services, you should be able to do that with e-services as well, can't you, Louise?
You can.
Okay.
What we do is 90% of ours are going to say, oh, by the way, could you look at this while you're here? So then if they're not eligible for the one, we just bill it as the level of office visit in the AR.
Mm-hmm. Okay. All right. Next. Yeah. And unfortunately for the person that came in before the time frame on the frequency, I think you're pretty much out of luck. But
yeah.
Okay. Next one.
Yeah, well, there's somebody who wrote in about what y'all were talking about and says the subsequent annual wellness visit, these are year to date exactly. Palmetto states the first of the month year to date. Call insurance or website. I'm not sure what she means. And then it says e-services all say the first.
Yeah. So you want to check e-services. If you're trying to schedule somebody to do an annual wellness exam, the first thing you want to do is check with e-services to see if they actually have one available and when the frequency limitation runs out so you can do it again.
I'm thinking it said like 11 months and 1 day. So it is in the same month that the previous one was done, but not necessarily 365 days.
Yeah, that sounds right. I remember reading that somewhere too.
11 months and 1 day.
And then somebody else asked, how can we get access to DDE if our clearinghouse doesn't support it?
Exactly.
I would, Ability, like I said, it's very, very cheap. It's like $100. So you may want a month. I've heard people say it's $50 or $100 a month for Ability. You can actually, there's a website. One of the links I had was direct data entry with Palmetto, where you can actually register to get access to DDE. I don't think they charge anything. They may or may not charge you anything for that. And then you may want to look at this PCACE software. The PCACE Pro is what they call it. I think that has built-in access to it as well. You're not going to want to use that to process all of your claims, but occasionally when you have a need for DDE or you need to do a Medicare secondary payer or adjust some claims, then that would be a situation where that particular software would work pretty well for you. Louise, have you ever seen that PCACE Pro software from the Mac?
Yes, when we were using our previous software, I actually had to use that for almost 18 months. It did not have the DDE built in.
Oh, it did not. Okay.
I think that was an add-on that did have a cost, but the software itself was free.
Okay, so that's where they get the money out of DDE. So how did you like using that software? I hear horror stories about how horrible it looks and how it took forever to do, and you know.
It took me back to the typewriter days of building a claim on the typewriter.
Yeah, that's pretty much what it is. So it's like a Unix space. It's really horrible. Okay, next up.
Okay, off-topic question, would Railroad Medicare be billed to Palmetto or Part B?
That answer changed a few years ago. Luis, do you know the answer? Because the answer changed, I can't remember if the old answer is right or the new answer is right. So
Ask the question again.
Railroad, do you bill Railroad to Part B, or do you bill it to, used to be there was a special place that you would bill Railroad claims, just like in Augusta, Georgia or something.
Yeah, it's always been separate from Medicare. I don't know how it qualifies with RHC.
Yeah. So
We don't have any.
Yeah, Carolyn Duncan, who used to do these seminars for us, she told me the correction, and I cannot. We'll look it up. We'll that's one that my brain just doesn't work on, but I will send it out with our materials there. So railroad claims, where to send it. I'm thinking it's billed to Part B, just like a normal claim now, which that seems strange to me, but I think that's what it is. But I'll double check because I'm not sure about my answer on that one. Okay, next question.
Nope, that's it.
Oh my goodness, thank you. These are always so hard. All right, everybody. Well, thank y'all for staying with us this long. It's been a long 2 hours. Thank y'all very much. Louise, thank you so much. You have saved the day on these things here, and we appreciate everybody. All of this stuff will go up on our website. That's what on RHC ruralhealthclinic.com/billing. That's where I'll put your answer for the railroad question there. You'll see something that says railroad on there, and you'll be able to get your answer for that. And but thank you all very much. We're going to close it out. Danny, thank you for all your help for these last few days. Do remember, we're having a cost reporting seminar on Thursday. It will not be 2 hours, I guarantee you that. So thank y'all. We will see you next time.
On Thursday, they're having one.